The breast screening project in East London took existing products and services and developed them further, making them more suitable and appealing to the target audience. What I really love about this project is that a lot of the changes they made were very simple and could be replicated anywhere for very little cost.
Historically, we've had very low uptake and coverage of breast screening in East London. In Tower Hamlets, we've had one of the lowest coverage of the breast screening programme in the country. From the period where we took this social marketing approach, we did actually see quite a big step change, and I think it was due to the level of focus we brought on it.
What we decided to do in our solution was to create a whole systems approach whereby we tackled three main groups. Obviously a priority for us was the client group, and we focused on Bangladeshi women and British and white Irish women because we knew that we had low screening rates amongst those groups.
We also did work with primary care because there's a lot of research that shows that GPs are particularly influential in women making decisions about their health care.
And finally we had our provider, who was Selbus, the City and East London breast screening service, and we wanted to ensure that their service became a client-focused service.
Good morning, breast screening. Got an appointment on the 15th of February, and she cannot make this one, yeah?
I think it's been fantastically rewarding for everybody, actually, because we've always had good clinical outcomes in terms of the number of cancers detected, but there was historically not great relationships with the commissioners in particular. And for me, the fundamental change has been the much better two-way communication. Regarding the funding, what we did was move from a block contract to a tariff per woman screened.
The problem with a block contract is it doesn't give any incentive to your provider to improve their service or do additional activity. By switching to a tariff and paying for each woman that comes through the door, suddenly the provider has a very powerful incentive to improve the service and to change the way they behave.
By offering second-timed appointments for women who do not attend the first invitation for screening, the possibility of offering extended hours of screening into the early evening and with intermittent screening on Saturdays, we can reach a number of women who otherwise might not have attended.
We work on an invitation basis, and we send an invite out to all the women that we know are eligible for screening. Now, we'd had quite a bit of feedback from other health professionals, GPs and practice nurses and the community about how the letter read. It wasn't very well set out. So we worked to kind of design a new letter and present it in a way that was easy to read, simple language, so everybody would have a really good chance of understanding what we were asking them to do. One of the things that is a particular problem in East London is people not being able to read English, written English. So we designed what we call the talking invitation, and we put the key messages in an audio clip that was inside the card. We had a local white woman from the community and a Bangladeshi GP who was also very well known within her own community.
One of the perceptions of the commissioners was that the service we were offering our clients wasn't particularly friendly or welcoming. And so we set about training the radiographers in human factors training.
What I'm going to do today is take a total of 4 pictures of your breast, so that's 2 pictures on each breast. What will happen is your breast...
That was very successful because it meant that for the first time the radiographers felt appreciated as well by the commissioning bodies, and off their own initiative they set up a human factors charter which they have in all the screening offices.
On the client side of this project, we'd identified British and Irish white women and Bangladeshi women as priority group, and it was important that we gained insight into this audience. So we were able to run focus groups with the audience to actually find out both their experience of screening and, for those who hadn't screened, the barriers that was preventing them from doing so.
The key success of the project was the targeting of women who DNA'd or did not attend their appointment, by directly phoning these patients to find out why they didn't attend and if there were any barriers that we could overcome by making changes to the service. What I can do is I can arrange for someone to interpret for you. We do have Bengali speakers available at the unit. I'll book someone in for you.
We worked with GP practices and patient who received their breast screening appointment as well as receive a phone call. They also received a text message through their mobile saying when and where their appointment is. We also have a project called Bosom Buddy project, which means a person who's been screened themselves were able to influence other local women by becoming a bosom buddy. So their role is to identify women who hasn't gone for their screening and support them to come for their screening.
The outcome measure that we're using is coverage of the programme, which is the percentage of eligible women over 3 years who've attended for screening. In the first year we got nearly a 10% increase, and it's continued to go up, so we're now at 67%, which is very close to the national minimum standard of 70%, which is actually our target that we're trying to achieve.